Good morning, everyone. For those of you who don't know me, my name is Jennifer Banayan. I am an obstetric anesthesiologist at Northwestern. I was invited today to talk about cardio-obstetrics, a field that's increasingly central to maternal health care. As Dr. Main highlighted, cardiovascular disease is the leading cause of pregnancy-related mortality, and pregnancy really places unique demands on the cardiovascular system, and managing those risks requires thoughtful care. So I'm editor of the APSF Newsletter, but I don't have any other disclosures. So I want to start with the case. This case really stuck with me, and so I just want to briefly talk about it and really what got me into cardio-obstetrics. So she was a 34-year-old G1P0 without any known cardiac history. And she came to the hospital late in pregnancy, and she was complaining of shortness of breath. And we couldn't tell at first if it was normal physiology or maybe some sort of asthma attack. But then in front of my eyes, she started to decompensate. We did a bedside POCUS, and I thought maybe her ejection fraction looked like it was beginning to be diminished. And so I got worried, but we moved quickly. We consulted cardiology, we moved toward her delivery, and she just kept worsening. And as soon as she delivered, she crashed on us. So we rushed her to the cath lab where she got a balloon pump, and thankfully she survived. But this patient taught me something I didn't expect. I am a fellowship-trained cardiac anesthesiologist. I work in one of the busiest obstetric units in the country, and I should have been ready for her. I didn't have a plan, even though I should have. I didn't have a clear protocol of how to handle what was going on. We didn't really have a system in place. We were kind of improvising the whole time, and she was decompensating in front of us. And that really made me realize if I wasn't prepared, how many others are not prepared. And that's really why I have such an interest in cardio-obstetrics, and that's why I'm here talking about this today. So in this talk, we're gonna talk about the prevalence of cardiac disease in pregnancy. I wanna talk about how it's a leading cause of maternal death. We're gonna dig into why this is happening. We'll talk about when the patients are most at risk. And then finally, we're gonna focus on how we start changing things. The goal really is simple. Can we be ready before things go wrong? So as we think about maternal mortality, it's important to start with the fact that measuring it accurately is not really straightforward, and Dr. Main kind of alluded to that. There are many publications and studies, and each of them uses something slightly different data sources. There's different time frames, there are different definitions, but whether we're looking at CDC or state-level maternal mortality reviews or large-scale studies, like the recent JIM analysis, no matter what we look at, cardiovascular disease is really consistently the leading cause of pregnancy-related deaths in this country. Again, depending on the source, cardiovascular causes account for a third of pregnancy-related deaths. They surpass hemorrhage, hypertensive disorders, infection. In fact, between 1999 and 2021, the rate of mortality death from cardiovascular causes tripled. This pie chart that I made kind of breaks down the cardiovascular causes of maternal mortality, like Jada was questioned. And as you can see here, peripartum cardiomyopathy stands out as the most common cause. And given its prevalence and impact, it's really a central focus of a lot of research and a lot of clinical interventions. But we see also distributions from coronary artery disease, arrhythmias, congenital heart disease, and aortic dissection. And when I created this chart, I wasn't sure, should we include hypertensive disorders of pregnancy? Should we include thromboembolic events, which I know Lisa's talking about today, because they're often reported all the time, but they're separately. They're usually taken out. But because they have such an effect on the heart, I included them also in this pie chart. Most of you have seen this figure before. It's the classic representation of the hemodynamic changes that occur throughout pregnancy. And I'm not going to go into detail on these parameters, but the key takeaway here is that pregnancy imposes substantial shifts to support the fetal needs. And these changes become especially significant during labor delivery and the immediate postpartum period. These rapid fluid shifts and stress can tip the balance, and that leads to volume overload or cardiovascular decompensation, particularly in our individuals with heart disease. And so, in other words, pregnancy is really just nature's stress test. People have heard this before, but it's very true. And so during pregnancy, the cardiovascular system has to undergo these dramatic physiological changes. And these changes are well tolerated by healthy hearts. But then you have a patient with underlying cardiac disease, and it's unmasked or it's worsened by this pathology. So patients who may be previously compensated or they are subclinical disease, they will decompensate when faced with these volume shifts and hemodynamic demands of pregnancy. And for those with really no existing cardiac disease, this could lead to our heart failure. This is why we see the arrhythmias. This is when we get the ischemia. Because pregnancy itself doesn't cause a heart disease, but it does reveal it. So why is cardiovascular disease the leading cause of maternal mortality in this high-income country? Well, there are several contributing factors, and so we're going to take a closer look at each of these. Here is Janet Jackson, pregnant at the age of 50. And like her, many women are delaying childbearing. In fact, 15% of all births in this country are to women over the age of 35. But a third of the maternal deaths are also seen in that age group. So with with a larger age, comes a greater burden of comorbidities. We have hypertension, we have preeclampsia, we're having thromboembolisms, we see diabetes, and all of those are elevating our cardiovascular risk. So when we talk about why maternal cardiac deaths are rising, the changing maternal demographics are really a big part of that story. And like we mentioned, not all cardiac disease is acquired. A growing number of patients are entering pregnancy with congenital heart disease. Thanks to major advances in pediatric cardiology and surgery, many of the patients are surviving into adulthood and considering pregnancy, and they have their own set of risks. In fact, the adult congenital heart disease population outnumbers children now in this country, and that's a testament to how far medicine has come. But these patients often face very complex challenges during pregnancy because their heart defects, the light's okay, and it repairs very widely. And that makes risk assessment and management particularly nuanced. Another reason cardiac disease in pregnancy is such a large contributor to mortality is that cardiac symptoms, like Elia said, like shortness of breath, like palpitations, like edema, they are just so common in pregnancy. And so they're often dismissed as normal, especially if you have a younger, healthier looking patient and they're coming to the ER with a not feeling so good, they're chalked up for anxiety all the time. But if it's someone with undiagnosed cardiac disease, these symptoms are our first warning signs, and when they're dismissed, it delays diagnosis and treatment, and timeliness is everything. And so studies show that up to 3/4 of cardiovascular-related maternal deaths are preventable. And delayed or misdiagnosis is a major contributing factor. And so this tells us all we need a higher index of suspicion, especially when symptoms escalate or don't fit our expected physiological pattern. But even when we do recognize the risk, we often fail to act effectively. And it's not because we don't care, and it's because our health systems are so fragmented. Many patients don't get the opportunity for preconception counseling, especially if they're uninsured or have limited access to specialists. And even when someone is flagged as high risk, referrals are hard to get to. Their appointments are hard to make. It's hard to get a spot. And when patients finally do reach us, their care is fragmented. So OB is managing their problem, maybe cardiology is seeing their patient for something, and then finally anesthesia gets there, and we're brought in the last minute without full context. And so it really becomes especially critical in the postpartum period when many of these cardiac deaths actually occur. Follow-up care is delayed or inadequate, and many patients are not seen postpartum until they show up in the ER decompensated. Now, we can't talk about maternal mortality, I know Jill's talking about this later, but without acknowledging the deep racial and socioeconomic disparities that exist in cardiovascular outcomes. In the United States, Black and Indigenous women are 2 to 3 times more likely to die from pregnancy-related causes, and that, again, cardiovascular disease is a leading driver. These disparities aren't fully explained by income or education. Even well-resourced women of color experience higher rates of delayed diagnosis, dismissal of symptoms, and undertreatment. And the reasons are multifactorial: implicit bias, structural racism, and unequal access to high-quality care. And then there's the social determinants of health, so housing instability, insurance gaps, transportation barriers, chronic stress. That all adds another layer of risk. Addressing maternal mortality means addressing these systemic inequities head-on. So now we've talked about why cardiovascular disease is the leading cause of maternal mortality, but let's talk about when these patients are dying. When we talk about maternal mortality, we often focus on labor and delivery. But for cardiovascular disease, the deaths don't happen during delivery. In fact, studies show that over half of these deaths occur in the postpartum period, after the patient's left the hospital. And I, too, sit on the Illinois Maternal Mortality Committee, and I'm overwhelmed by how many patients go to the ER multiple times before they ultimately end up dying in their home. And so the timing varies by disease. So peripartum cardiomyopathy presents weeks to months after birth. But then an aortic dissection we can see right after delivery. And so for those of us who are anesthesia professionals in the room, our care often ends at delivery. But we may be the last person to see this patient, to identify the risks, to optimize the status, to raise concerns, especially in these patients who have really subtle symptoms. I think it's on us. So we've talked about the scope of the problem, the rising rates of cardiac disease at pregnancy, why it's happening, and when it's becoming dangerous. And the question is there anything we can do? What can we do? The first intervention is identifying the cardiac risk before pregnancy or early on in gestation. Now, as anesthesia professionals, we rarely get to see these patients before delivery, never mind before pregnancy. But more and more institutions are establishing prenatal consult pathways, and that does allow us to get involved earlier. These consults allow us to risk stratify patients and flag any concerns. We have tools a little bit now to help us. So we have Zahara, the MHU, the CarPreg, and all those can kind of guide counseling and decision making. And even though if we're not part of the initial prenatal care, that can help us when we see the patient in the pre-op, when they come to delivery, we can gather, and hopefully that'll help the trajectory of care using those tools as well. Of course, identifying risk is only the first step. What really changes outcomes is what we do once that risk is recognized. And so that brings us to one of the best tools we have, which is multidisciplinary care. And one of the most effective ways we found to improve outcomes through pregnancy is through this pregnancy heart team. It's this team that comes together specialists. It includes OB, cardiology, anesthesia, MFM, nursing, and we all come together to collaborate. And the goal is better communication, safer, more proactive planning. It helps avoid the last-minute chaos of decisions when the patient decompensates. And studies show that institutions that have formal cardio-obstetric programs have lower rates of cardiac complications and better maternal outcomes. For anesthesia, being embedded in this part of the team makes a real difference for us. So at Northwestern, we recognized the need for this kind of coordinated care, and we built a formal cardio-obstetric program. We meet regularly and review every viable pregnant patient with a cardiac diagnosis, and it gives us a chance to make a detailed delivery plan before the patient arrives in labor. But this brings us to a really important point. While the pregnancy heart team is incredibly valuable, anesthesia needs a seat at the table. Anesthesia professionals have been managing high-risk obstetrics with cardiac disease for a very long time. We've been publishing our clinical guidance, our case studies, our institutional experience, and they're all in our own specialty journals, though. But as cardio-obstetrics has emerged as a formal multidisciplinary field, a lot of the foundational literature, like the AHA scientific statement and ACC consensus statements, they're all from cardiology. And finally, in 2022, the AHA approached a few of us as anesthesiologists, Katie is another author in the room, including myself, but to write a scientific statement on the anesthetic care of the pregnant patient with cardiovascular disease. The statement became one of the first articles in circulation focused on anesthesia's role in cardio-obstetrics, and it was a meaningful step. It said anesthesia isn't just a consult, we want to be part of the core team. And now it's really up to us to keep pushing forward, to write, publish, collaborate, and lead. Because when we are involved early, then we're embedded in the planning, outcomes seem to be better. So now that we've covered pre-delivery planning, we want to focus on the crucial role anesthesia providers during labor. So labor and delivery, as many of us know here, are intense cardiovascular stress, increased cardiac output, fluid shifts, and anxiety, and they all cause significant changes. And so our expertise in monitoring and managing these changes is really essential to help patients throughout their labor. Placing invasive monitors like arterial lines can help us give real-time data to catch subtle changes before things escalate into emergencies. Fluid management has to be really carefully tailored. Too much fluid and we're in heart failure, too little and we're hypotensive, not perfusing the uterus, and going to crash C-section. We've often the first to detect arrhythmias and intervene promptly to prevent deterioration. In rare but critical situations, ECMO can be a life-saving intervention. I won't talk much on ECMO, but the utilization of ECMO in maternal cardiac care has significantly improved survival rates in critical cases. For instance, in peripartum cardiac arrest scenarios, VA ECMO has achieved a maternal success rate of up to almost 87–90%, and nearly 80% of those survivors have no neurological deficits. So managing these patients during labor is critical, but it's only one piece of the puzzle. We've already talked about how the postpartum period carries the highest risk, so how do we manage these effectively? At Northwestern, we realized the standard postpartum care wasn't enough for many of these patients, and we built something different. I don't know why my slide is blank, but we developed an intermediate medical unit specifically for high-risk postpartum patients. One of these patients to stay close to their babies while remaining on continuous telemetry. This unit now has a higher nursing ratio, more frequent assessments, and really the ability to respond quickly if patients start to decompensate postpartum. And that is helping us bridge the vulnerable window between delivery and discharge. So I began this talk with a patient who told me how unprepared I was, even at a top institution, and then we talked about what's possible. Anesthesia professionals do have a powerful role to play in a cardio-obstetrics, but not just in the OR. We need to recognize risk, we need to shape plans, we need to push for better systems. It's not just about preventing emergencies, it's about creating care models where patients with cardiac disease can deliver safely, recover well, and thrive. Thank you.